Okay. Good afternoon. Today, for a topic, we have a very basic topic: collection of blood and anticoagulants. So, this is basically we're going to learn for which test, which sample you should send, and which anticoagulant is there, and what is the color of the vacutainer. So, you'll have to remember this throughout your life. Okay. So, just to okay, how do I move to the next slide? Actually, how do I move to the next slide? Okay, just to start off with the universal precautions, you have to assume that every patient is infected, especially now with COVID. We all have taking a lot of precautions. So just to remember, we have to wear disposable gloves, prevent injuries, especially while handling sharps, and discard all sharps in puncture-resistant containers. Do not recap the used needles. Disposable syringes are used, and do not reuse any of the instruments. Now, coming to the type of sample and the site from which we take and for what test we take. So, we have the capillary blood, which we usually obtain from the earlobes or the digits of usually the third or the fourth finger. Or in infants, you prefer the heel and big toe instead of the fingers. And this is preferred when you need very small quantity of blood, like, for example, to make a peripheral smear or just do a reagent strip or blood grouping. The most commonly sampled is the venous blood, which we obtain from the cubital vein. And if that is not available, then the dorsum of the hand. This is used for our blood routine in our setup. Then we also have arterial blood, which is taken directly from the artery, carotid, femoral, or radial artery, which we use for ABG, that is arterial blood gas analysis. There is some difference between our capillary blood and our venous blood. So, what are the differences? That is, capillary blood will be having a PCV, RBC count, and hemoglobin, which is slightly greater, and also a TLC, that is total WBC count, and a neutrophil count around 8% greater, and a monocyte count, which is around 12% greater. So basically, PCV, RBC, hemoglobin, and the WBCs are slightly higher in capillary blood, while in venous blood, we have a slightly higher platelet count. And that is basically because whenever there is an injury, platelets will adhere at the site of the injury, and that will lead to an increase platelet of around 9 to 30% in venous blood. Now, coming to our capillary blood, which we know the most commonly obtained from finger pricks sample, that is used only when we need a small amount of blood or in patients in which we are not able to get a good venous sample, or if only there is only one good vein and you're saving it for another procedure, or of course in uncooperative patients, which is a possibility. So where do we obtain it from? Usually from the third and the fourth, that is the middle of the ring finger. And in children, we prefer the heel sample. We take it distally, not in the center, because you could injure the calcaneum and again lead to osteomyelitis and so. So these sites are distal lateral aspect of the middle of the ring finger, not from the dominant hand. That is a non-dominant hand, heels and toes in neonates and young infants. Now, procedure, I'm sure we all know, but just to understand, massage the finger 5 to 6 times and gently milk it. Do not squeeze it. You cleanse the site with ethanol, and with a quick motion, quick stab, you have to make a puncture which is 2 to 3 millimeter deep using a lancet. And you discard the first drop because the first drop is often contaminated with tissue fluid. So you discard the first drop. The disadvantages, of course, is that some amount of tissue fluid will always be there. Platelets will be greater because we already learned there is platelet adhesion at the site of injury. And we can get very small amounts of blood only. So you can use it only for a few tests like blood grouping or reagent strips or peripheral smear. And squeezing, we tend to squeeze even if we know that theoretically we are only supposed to milk and not squeeze. You tend to squeeze, and that will only express blood which is more contaminated and cause erroneous results. Now, this is the obtaining venous blood by phlebotomy. Of course, this is the cubital vein which is being shown. This preferred site is the cubital vein and even the dorsum of the hand. And this also, we all know the procedure. 19 to 21 gauge needle is used after cleaning with 70% alcohol. We tie a tourniquet to the upper arm and introduce the needle at an angle to the skin surface with the bevel side up. You stabilize the vein and introduce it in, loosen the tourniquet when the needle is inside, and withdraw it slowly according to the rate of filling of the vein. Detach the needle and then deliver it to container with anticoagulant. And the precautions to prevent hemolysis include you have to use a clean and dry apparatus, because if there is moisture, then again the RBCs can swell up and cause hemolysis. Fine bore needles should not be used because the aperture of the needle, the diameter is very small. So when the RBC passes through this thin diameter, they tend to break. You withdraw the blood slowly. Do not apply a lot of vacuum because, again, because of the pressure difference, they may break. Mix gently with anticoagulant because we all know we are supposed to mix and we tend to get very aggressive with the mixing, but you're supposed to mix very gently. And before putting it into the vacutainer, you have to detach the needle because, again, if the blood goes through the thin needle, then it may hemolyze. Containers, traditionally glass or plastic tubes were used, so silicone coated tubes for coagulation studies. But now what we prefer is the evacuated tube systems. So this is the vacutainer blood collection system where we have here the needle holder is there, and inside here we place the tube in which we are going to collect the sample. And the glass tubes tubes are sealed with the rubber stoppers. And each of the tube is color coded, so we can pick out which anticoagulant is there in each of the tube. Now, these are the different tubes which are available. And again, to explain the parts of a vacutainer system, we have the needle, the cover of the needle, the holder, and the vacutainer. Different vacutainers with different colors. So you have to remember the color and which anticoagulant is present in each of the vacutainer and which are the tests which you will be sending the sample. So first we have this yellow tube or the red tube. Both of them are plain tubes. The red one has no anticoagulant. The yellow one has a clot activator. You can see this gel-like substance here. This is the clot activator. So in AIIMS, we don't have the yellow. We don't have the red one. Instead, we use the yellow one, which is basically the purpose of both the same. So you won't get to see the red one here, but once you go outside, you might be seeing only the red one, which is a plain tube. So this plain tube does not have any anticoagulant, and it will have a clot activator. So basically, when you put the whole blood into it, clot formation takes place, and you'll be able to isolate the serum alone, which will be in the supernatant. So for all the tests which require serum, that basically the biochemical test will be performed using these vacutainers. Now we have this lavender or purple color, which is EDTA. EDTA is used for routine CBC, routine complete blood count or blood routine, and for ESR. We can also use it for ESR, but actually citrate is preferred for. Then we have the heparin tube or the green tube, which has lithium or sodium salt of heparin. Then we have the gray one, which has oxalate with sodium fluoride, potassium oxalate with sodium fluoride, which is used for blood glucose. Because sodium fluoride, we have all learned in the glycolytic pathway, is inhibited by sodium fluoride. So we use it for estimating the blood glucose. Next, we have the blue tube, which has sodium citrate. Sodium citrate is the anticoagulant of choice for all coagulation-based studies. Now, this is again the vacutainer system. We have the needle and the adapter and the holder and the blood tube. This is how we collect the sample in. So the advantage of the vacutainer system is that with just one prick, you'll be able to take multiple samples. So you prick the patient once, you fill this tube, then the next tube you can insert. So multiple samples can be collected with just one prick, which is more convenient for both the technician as well as the patient. So this the vacutainer tube is pre-packed, and it can collect 2 ml, 4 ml according to the capacity of the tube. So exactly that amount of blood will be collected in the tube because of the vacuum that is there in the tube. So it will suck out exactly what the tube is meant for. So the advantages is, one, you can change it with a single prick itself. You can get multiple samples. Second, the amount of blood that you draw will be precise for the vacuum container that you are collecting. Third, you are not exposing yourself to any of the blood, and disposal is also easier. And you're not opening the container at all. So again, there is no spillage, and you're safer. Now, coming to the anticoagulants that I use, a very broad classification would be calcium chelators. Sorry for the spelling mistake. Calcium chelators are there, and non-calcium chelators. Non-calcium chelators include heparin and warfarin, while the calcium chelators include oxalates, which are ammonium oxalate, potassium oxalate, or a mixture of both of them, which is the double oxalate. And the others are EDTA and trisodium citrate. The non-calcium chelators include heparin and warfarin. So coming to the anticoagulant, the most commonly for blood routine, what we use is the sodium or potassium salt of EDTA. Lithium salts are also available, but most commonly used are sodium and potassium. So we have they are used around 1.2 mg per ml. And then we have trisodium citrate, which is available in two concentrates. One is 3.8 gram percent and the other is 3.2 gram percent. So if it's used in a ratio of 1:4, it is used for ESR, and 1:9 is for coagulation studies. So this concentration is important, the percentage, as well as the ratio and for which test this is used. So 3.8 gram percent at 1:4 ratio for ESR and 3.2% at 1:9 ratio for coagulation studies. And does anyone remember the color of the sodium citrate vial? Shubham, can you answer the color of the sodium citrate vial? Shubham? No. Anyone else? Any volunteer?
Ma'am, blue.
Okay, thank you. Okay, and then we have double oxalate. Do you remember double oxalate ka color? Okay, we have double oxalate. Oxalates may we have ammonium oxalate. Okay, thank you. Oxalates may we have ammonium oxalate as well as potassium oxalate. And when you use a mixture of both of this, that is ammonium oxalate 1:2 gram and potassium of 0.8 gram in 100 ml of distilled water, it becomes a ratio of 3:2. So this ratio of 3:2 is called double oxalate, also called Wintrobe's mixture. So can anyone, this Wintrobe name is pretty common. So anyone knows anywhere else where this Wintrobe is there? I mean, it's there in multiple places. Can you name anything which has a Wintrobe in it?
ESR, when we count ESR, we use Wintrobe's tube.
Okay, very good. Wintrobe tube ESR can be done with Wintrobe tube. Anything else?
Packed cell volume, PCV.
PCV is okay. Okay, both basically Wintrobe tube you're saying. Anything else with Wintrobe? Other than the tube? It's just trivia that I'm asking. It's not really important. Have you heard Wintrobe ka book? Wintrobe book on hematology. Just like Robinson Pathology, Wintrobe has written a book in hematology. This is pretty nice. And if you come to know any other Wintrobe, let us also know. Okay, I forgot the other Wintrobes. So double oxalate is basically ammonium oxalate and potassium oxalate in a concentration of, in a ratio of 3:2. So 1.2 plus 0.8, that is 2 mg per ml. And next we have heparin. Heparin tube was what color? It was green color. Okay. Heparin will activate antithrombin 3. So basically, it's an inhibitor of thrombin formation. And it is used for osmotic fragility. Anyone can knows why osmotic fragility is done? Indications of osmotic fragility? Oh, very good. Okay. Okay, I'm trying to change the slide and okay. So once again, calcium chelators, basically you all know the coagulation pathway and calcium is a very important part of it. So what the calcium chelator does is in the name itself, it chelates calcium, especially oxalates. They'll form an insoluble salt along with calcium, that is calcium oxalate, and hence the calcium is not able to take part in the coagulation pathway and hence anticoagulant role. The basis of using the double oxalate is that ammonium oxalate causes swelling of the RBCs and potassium oxalate will cause shrinkage of the RBC. So if you use it in a ratio of 3:2, basically they balance each other out and the morphology will be maintained. That is why it is called balanced oxalate, double oxalate, or Wintrobe's mixture. And because the name Wintrobe's is there, you can remember it is used for PCV. Okay. Just remember PCV, hemoglobin and all, we prefer the EDTA tube only, not oxalate tube. This is just theoretical, but hemoglobin is EDTA tube. Oxalates we use for PCV. It's also called Wintrobe's mixture and it is performed with a Wintrobe's tube. Now coming to EDTA, which is ethylene diamine tetraacetic acid. This is the preferred anticoagulant which we use for blood routine as well as for peripheral smear. Of course, peripheral smear, we always prefer a fresh finger prick smear. But if that is not available, then you can also take an EDTA sample and make this smear without much delay. It usually uses disodium or dipotassium salt, and it's a very powerful chelator. That's the dose of around 1.2 mg per ml. And what is the color? EDTA?
Lavender.
Oh. Now, citrate, 3.8% is there, 3.2% is there. Remember the ratio, ESR, 1:4 ratio, 1:9 if it is used for coagulation studies. Now, citrate is also a part of the several different anticoagulants which are used in the blood bank during our blood donation, which includes ACD, that is acid citrate dextrose, or CPD, which is citrate phosphate dextrose, or CPDA, where we add adenine as well. So citrate is used even in blood bank. Heparin, we already learned it, antithrombin 3 it is, which thrombin is required for conversion of fibrinogen to fibrin. Now, the use of heparin is mainly for arterial blood gas, ABG, or fragility, or even immunophenotyping or flow cytometry can be done in heparin, but we prefer EDTA for it. The disadvantages is that heparin is highly acidic and it causes a bluish discoloration. So never make peripheral smear or bone marrow smear or any kind of smear in heparin because it causes a bluish discoloration. So you will not be able to get a clear background and it will be difficult to identify the morphology. Another disadvantage is it's expensive. It is not available in all the wards. Okay. So heparin, remember, bluish discoloration, and it is an antithrombin 3, and the uses osmotic fragility, immunophenotype. And so fall in WBC count. RBCs can get crenated, so they can shrink. Okay, so again the PCV will reduce and the MCHC will increase. Okay, and heparin we already learned useful even for a CBC. Now, effects of storage. Now, in a few hours, RBC will start to swell. So once the RBC swells, the PCV will increase, the MCV will increase, and it will become more fragile. The osmotic fragility will also increase. Platelet count will fall. Reticulocyte will fall in the first 24 hours if you refrigerate it. If you don't refrigerate it, then it has to be performed by 6 hours of collection itself. Then counts will be stable for around, if you store it, at least you should store it at 4 degrees Celsius. After 2 to 3 days, obviously, frank hemolysis will start. So these are some of the artifacts that you can see. What are these RBCs? Can you tell? Anybody tell? These are the crenated RBCs. Okay, and what is the cell?
A neutrophil.
It's a neutrophil. And is there something wrong with this neutrophil? Does it look like a normal neutrophil? The two nuclei.
I mean, there isn't a lot of segregation.
What is this? What is happening?
Okay.
So the different lobes have started clumping together. Then what about this?
It has compromised membrane, probably osmotic.
Yeah, it has started autolysis and disintegration. Okay, and vacuoles have started to come. The lobes have started to, like separation of the lobes are not clearly visible. So these are the different effects that storage can cause. So it is always ideal to either store at 4 degrees Celsius or do the smear exam, make a smear at the earliest. Okay. The outer time limits are 2 hours for PT, platelet count, and peripheral smear. And ESR ke liye you can keep for 3 hours, 24 hours for an RBC count, hemoglobin, PCV, TLC, retic count, if you're storing at 4 degrees. So this is coagulation. It's just basic on coagulation. Because the class is so small, we can take another smaller topic today.
Excuse me, ma'am.
Yeah.
Ma'am, can we do all the tests that we did in capillary blood with venous sample?
But the point is, capillary blood, you'll be able to get only few drops. So again, like a blood grouping, you need only 1 drop. So that's what you can do. A reagent strip also you can do with.
If for some reason we had already collected a venous sample, do we need to actually collect a capillary sample?
No, not really. But again, the time is important, because if you store in EDTA, again, we learned that number of morphological changes can occur. So you can try first with EDTA, and if you feel that there are some artifactual EDTA changes, then you can go in and ask the patient to repeat with a fresh finger prick sample itself. Okay.
Okay, ma'am. Okay.
Is my peripheral smear preparation and staining visible?
Yes, ma'am.
Yes, ma'am.
Yes, ma'am.
Okay. So I know we are taking just a theory class of the practical. We are supposed to we have made like 100 stupid peripheral smears in our MBBS. Even then we couldn't get a good peripheral smear. I don't know how we all are managing at home, but now we're forced to take theory of the practical also. So at least learn the theory part. So you can answer your Viva at least. Okay. So coming to introduction, peripheral smear, the big advances which are coming. Peripheral smear is always the foundation. Morphology is very, very important, and do not dismiss it just because it is cheap and it is basic. Okay. So it's a very powerful diagnostic tool which you should not underestimate at all. So indications, these are just a basic indication. One is for anemia. Okay, then pyrexia of unknown origin. You'll be able to see whether there is any atypical cell or not, or whether there is any parasite or not. Which are the hemoparasites that you can pick out in peripheral smear? Or any hemoparasites you know?
Malaria parasite.
Any hemoparasites? Okay, thank you, malaria. Then,
Brucella.
other than malaria, anything else we can see?
Microfilaria.
Still, not really hemoparasite. Very good, microfilaria. Anything else?
Babesia.
Okay, very good, Babesia. Again, all these are your MCQ questions. But the look that Babesia gives in peripheral smear. Okay, it's called Maltese cross. That is an important MCQ. And any other? You've already told the common ones: malaria and filaria, microfilaria. Anyone knows the rarer ones?
Trypanosoma.
Very good. Trypanosoma. It causes sleeping sickness. We don't get to see it much, but we have. It was my MD exam spotter. Any other hemoparasite you know? Very good. Anyway, you've answered like 4, which is a very good number. There's also Ehrlichia, Anaplasma, etc. So you can read it up. And you can see the photos because it can be asked for spotters or MCQ image based. You can also use it to study platelet morphology, platelet count and morphology in cases of bleeding disorders. And you can rely on peripheral smear obviously to see atypical cells, that is lymphoma, leukemia infiltrates. That is when a patient has a loss of weight, loss of appetite, lymphadenopathy, hepatosplenomegaly, and all. You can rely on peripheral smear. So peripheral smear is basically a window to see how your bone marrow is performing. And it's a very simple, non-invasive test. You only need 1 drop of blood, very simple staining as well, very simple preparation. And so that is the first test that you're doing with CBC along with a peripheral smear. So there are peripheral smear itself, there is a thin smear and a thick smear. Anyone knows why we'll make a thick smear? Why we make a thick smear? What is the advantage? Routine when you think of peripheral smear. Okay, very good. Routinely when you make a peripheral smear, do you make a A or a B?
A.
Very good. So you said malaria. So why would you make a B for malaria? Why can't you just make A and send? What is the advantage? Do we need a B or A is enough?
We can make like both have their advantages in malaria. Like for speciation, we can make the A smear, and for identifying this, that is there a malarial parasite, we can make the B.
Very good. So what are the different species that you see? Malaria in blood?
Vivax, Oval,
Vivax,
Falciparum.
Oval, Falciparum.
Falciparum.
Then I couldn't hear. Did anyone try to tell something else? So he told Vivax, Oval, and Falciparum. Did anyone else for anything else, or only 3 are there? No one else.
Malaria and
Malaria.
knowledge.
That's what I'm malaria.
Very good. Malaria. One more.
Knowledge.
Very good. So there are 5 species. Okay. And is identifying the species important or no? Which is the most severe? form in which you have to inform the clinician immediately. Very good. Falciparum, because it can cause CNS also effect. Okay. So for the basically thick smear, the advantage is that you are getting a huge, large drop of blood. So you're getting more quantity of blood, and so you can pick out with greater sensitivity if there is a parasite or not. So you'll be able to tell is parasite present or not because you're examining a larger amount of blood. While thin smear, you can see the morphology clearly and try to characterize which species it is. Okay, so both of them, ideally, you're supposed to do both of them if you are suspecting a malaria and pyrexia of unknown origin. Okay, so remember this when you go become interns and go to ward. Send both. Okay. Now, coming to thin smear, we always prefer a finger prick smear, but because of our easiness to do in the practical setup, we do a venous blood and make a smear from that. And remember, try to make it as soon as possible. Don't be late, especially not more than 2 to 4 hours, because we learned the different changes that can come in EDTA, which will make your morphology difficult. And you will tend to overdiagnose patients. Now, there are different methods of preparing a thin smear. Theoretically, you can use a cover slip or an automated spin method and all. But what we usually do is a wedge method or a 2-slide method, which you should all be well versed with. Okay. Because in institute like AIIMS, of course, a technician will prepare your smear. But in other medical colleges, like from where I came, we had to make our own smear and then send it to the lab. Lab people didn't used to do anything. Okay. So you have to know how to make a good smear. It's not just for exam. So we have the wedge method. Remember, you have to use clean slides. Now, people think that clean slides means I'll buy a new pack of slides, okay, and make a smear on that. That is not a very good idea because new slides, the manufacturer usually to make it look more shiny and clean, they use a thin coating or of polish on the slide. Okay, so to us it looks very shiny, but once you stain it, the polish will take up the stain and it will again cause a blue background. So it is always a good idea to wash your slides with soap and detergent and water, even if it is new slide. Okay, so you clean your slide and wipe it nicely. There should not be any moisture, or again, hemolysis can occur. And you take a drop of blood, not too much, not too less, around 2 to 3 millimeter in size, and you place it 1 centimeter from one end of the slide. So again, anyone guess why this 1 centimeter gap from one end of the slide? Why do you want to leave a 1 centimeter gap? Why can't you just start it off from one end of the slide to the other? No one. Hello, am I audible? Did my connection go? Am I audible?
Yes, ma'am, you are audible.
Okay, so yeah, everybody was silent, so I thought like I lost my connection. Just guess, no, why 1 centimeter will be left?
For labeling, no?
Very good. For labeling. Okay, you need to write the UHID or slide ka number, the patient's name. So that part is left for labeling. So you place the drop, one slide. So you need 2 slides. One for spreading. Now the spreader slide should always be a smooth edge. Okay, and a very good slide should be reserved and kept for your spreader slide. And it is placed in front of the drop. So the drop of blood is always behind the spreader slide. Okay, don't just put the drop and then push off. No, you have to place the spreader slide in front of the drop, pull it behind to touch the drop, and the drop will spread along the edges and then drag it in a quick and steady motion. Okay, So I don't know, have you made in physiology peripheral smear? Have you ever made peripheral smear? Are you able to like understand what I'm telling, or?
Yeah, we've made.
Okay, then you all know. Okay, my slide is not moving. Okay, and how many of you got an ideal peripheral smear when you made it earlier? Nobody? Okay, at least you should know and theoretically what went wrong. Okay, and if you answer your Viva well, you'll definitely pass, even if your peripheral smear is very far away from ideal smear. So the criteria of an ideal peripheral smear is it should be tongue-shaped, 3 to 4 centimeter long. It should not touch the edges of the slide. It should be smooth without any holes or any veils. And the parts, there is first head, body, and tail. So the head part will be the thickest part, and the tail will be the least thick. And where do you examine? Do you use the tail or the body or the head? Where do you use look peripheral smear? Examination is done which part of the peripheral smear? Is it body, head, or tail?
Junction of both.
Direction of the body and tail.
Very good. Why? Why junction of body, head, and tail?
Overlap there.
I mean, body and tail. Because? What? I couldn't hear.
Not much overlap there.
Very good. So the RBCs are just touching each other, so you'll be able to see the morphology very clearly. Now, this is again the steps which we already know. Place a small drop of blood, and then you place the spreader slide in front, then take it behind so that the blood spreads to the edge, and then push it in a continuous manner. So mine used to look like this now, but it has started to look like this, but it took many, many years to do it. So what is wrong with the smear? Anybody? There are like many, many things wrong with the smear.
It's not tongue shaped. It touches the borders. It's
Okay. Yeah.
not uniform.
And what is this?
Breakage in between.
Bubble.
Ridges are also come in
Bubbles.
between. There are holes in between. Yeah, holes. And okay. So when you're drying a smear, how will you dry it? Will you like blow on it, or will you keep it in a corner, or will you keep it under the fan? What is preferred? Is it slow drying is preferred, or fast drying, or blowing on it will dry it faster? What do you think? Or a hair dryer also you can use. What do you think? Which is better? Sometimes you're so impatient, no, dry fast, and will be blowing on it. What do you think about that?
Spontaneous spraying on its own.
Okay, on its own, better to keep it under a fan or a hair dryer. Hair dryer, of course, we won't have, but place it in a slanting position under the fan. Why not to blow on it?
It's not a sterile way.
Because when you blow on it, there are also there's a bit of moisture in your breath. So small droplets of water will be there, and that will create a water artifact. That is, the water will enter into the RBCs, and you won't be able to understand is the RBC hypochromic or not, or is it hyperchromic. The chromia you won't be able to understand. The RBC morphology will all look, because the water has entered the RBC and it is forming a refractile droplet. You won't be able to understand the RBC morphology. And Ma'am has asked me to ask the few questions from the previous just to make sure that you all are studying. So, how will you understand is RBC microcytic or macrocytic? What will you compare it with?
Compare it with nucleus of a small lymphocyte.
Small lymphocyte.
Small metro. Very good. Okay, so these are just if your peripheral smears look like this, at least know what is wrong, accept it, and tell the mistakes and how an ideal one should look. So, can anyone just summarize how an ideal smear should look? Features of an ideal smear. Hello?
The smear shouldn't touch the borders. It should be tongue shaped. There shouldn't be any ridges or any holes.
Okay. Hmm. 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 And what about the length?
3 to 4 centimeter in length, and
Cover
the
3
end should be
Okay. Okay. So another thing is we learned that the spreader slide should be kept at an angle of 30 degrees. So is this angle constant? Can you increase or decrease the angle? What do you think? Is there any condition where you need to increase the angle? Is there something where you should reduce the angle? Okay, I'll just give you like options. Suppose there is anemia and there is polycythemia. You all know what is polycythemia, right? Opposite of anemia, where the RBC density has increased. So if there is an anemic patient, that is severe anemia, and there is a polycythemia, in which case will you increase the angle? In which case will you decrease the angle? And why?
Angle
In anemia, angle will increase.
will
We will decrease the angle in polycyclic.
Okay. Oh, very good. Why?
If we decrease the angle, there will be more distance, so that RBC will spread apart.
Yeah, very good. People know everything already. Okay, this is again the same thing. Now coming to thick smear, how will you make a thick smear? So you take one large drop of blood and you spread it to around 4 times its volume. Its diameter will be around 1.5 centimeter. Okay, and the ideal thickness. How do you thick smear? What is the ideal thickness of a thick smear? What do you think? Anybody? Okay, so it should be thick enough that if you place the thick smear in front of a newspaper or any printed paper, you should be able to see the print on the paper. Okay, it should not be like a thin smear, but it should be thick, but you should be able to read the print of a paper. Or if you don't have a newspaper, suppose now nobody reads newspaper anyway, so you have to place it on your watch and you should be able to see the dial or the what do you call it, hands of the minute and the second and all you should be able to see. So it should be thick enough that you'll be able to read the fine print on the newspaper or at least see the dial of your watch. So it shouldn't be like over thick also. Then staining. What is the difference between staining of a thin smear and a thick smear? Any difference? Anybody? Okay, I'm again going to assume that I've lost my internet connection. Am I audible?
Yes, ma'am, you are audible.
Okay. So, what any difference in staining? One thing that is written here is pH should be 7.2. Usually, Leishman stain has a pH of 6.8, but in malaria, it is better if it is 7.2 because that brings out more distinction in the malarial parasite granules. You'll be I don't know if you know the different stages which are present. So this 7.2 pH will bring out the contrast in the malarial parasite. So remember this also, 7.2 is in when you are looking for malaria. 6.8 is in the routine ideal pH. Another thing that you do is a thick smear. The only purpose of thick smear is to see whether there is a parasite or not. So what do you need to do? Parasite is inside where? Is it in the RBC or is it in the WBC or is it in the platelet or is it lying outside? What do you think? Parasite is where? Is it extracellular, intracellular? Intracellular means where inside the RBC, WBC, platelet, where?
Intracellular in the RBC.
Very good. So it is an intra RBC. So in order to see the parasite properly, you need to lyse the RBCs, right? Then only you'll be able to see the parasite will jump out. The RBC red color will be gone. The background will be clear, and you'll be able to pick out the parasite. So that's why first you need to dehemoglobinize the RBCs. So the first step before staining is dehemoglobinization. Now, this is done by just dipping multiple times the peripheral smear you prepare. You dry it for half an hour and then you dip it multiple times into distilled water till the smear becomes clear. Okay, so the first step is dehemoglobinization so that the red color of the RBC is lost. You get a clear background and you'll be able to pick out the parasites clearly. So that is the two differences in staining of a thick smear and a thin smear. One is the pH 7.2 is preferred because the contrast is greater there, and you need to remove the hemoglobin so that you can pick out the intracellular parasite. Another advantage of the thick smear is that you can see 1.5 centimeter square only as the volume, while the thin smear will be 3 to 4 centimeter in length. So you will have to take much more time to examine a thin smear than to examine a thick smear. A greater volume is also there in thick smear, and time is also easier in thick smear. That is the advantage. So these are examples of thick smears. Now coming to basic peripheral smear staining, we'll be learning the Romanovsky stain. Basically, Romanovsky is a huge criteria. There are many stains under the Romanovsky stain. And the Romanovsky stain, if anybody asks you what is the Romanovsky stain, it is a stain which has two components. One is basic, one is acidic. So why do you need a basic and an acidic component? Because opposites attract. The basic part will stain the acid part of the cell. Where is the acid of the cell present? They're basically nucleic acid. Nucleic acid is present in the nucleus. Okay, so the basic part of the stain will go and stain the nucleus. That is usually the basic is the methylene blue. That's why in the cells, the nucleus will be blue in color because methylene blue is basic and it gets attracted to the nucleic acids in the nucleus. The acidic part, usually we use eosin, and that is attracted to the basic part of the cell, that is the cytoplasm. So Romanowsky stains are stains which have two components. One is basic, one is acidic. Opposites attract. So the basic methylene blue will attach to stain the nucleus, and the nucleus is always blue, and opposite for the cytoplasm. So basically, Romanowsky stain has these stains: MGG, that is May Grunwald James stain, Jenner stain, Wright stain, Leishman stain, Peel stain. Okay, so you have to know the names also. Everybody asks, what is Romanowsky stain? Why is it? What is a Romanowsky stain? What are the examples? MGG, Jenner, Wright, Leishman, Field. Well, Jenner is the simplest, James is the most complex, and Leishman is somewhere in between. So usually, the most widely used for peripheral smear is Leishman. Okay, there are many institutes which also use Jimsa like us. We use Jimsa. So for your exam, Leishman stain will be asked. You need to know 0.5 gram Leishman powder in 100 ml acetone-free methyl alcohol. Now these words are very important. 0.15 gram Leishman powder in 100 ml acetone-free methyl alcohol. So this acetone-free methyl alcohol is your fixative. What is a fixative? Basically, it just helps to fix your smear onto the slide, so that it does not, your smear doesn't get washed off when you pour water and do the staining procedure. Okay, so the fixative is acetone-free methyl alcohol. And of course, Leishman powder has a methylene blue, which is the basic part for the nucleus, and it has an eosin, which is the acidic stain. This is principle we've already learned. Opposites attract. And the method you have to know, which you have to pour the stain, and you have to count the stain. Suppose 10 drops of stain you are putting. Okay, so what is basically the stain? 0.5 gram Leishman powder, 100 ml acetone-free ethanol. Okay, suppose you're pouring 10 drops of the stain. Stand for 2 minutes. In that time, the acetone-free methyl alcohol will act and fix the stain, fix the smear. Because the first 2 minutes there is no staining, there is only fixation. Okay. Then you pour distilled water. Now this distilled water should be double the volume of the stain that you have put. So suppose you put 10 drops in the stain, you are at 20 drops of the distilled water. Okay. And then this distilled water will split it into, will allow the differential staining. So what is the use of distilled water? It allows differential staining. That is, it allows the methylene blue to go and stain the nucleus. It allows the eosin to go and stain the cytoplasm. So remember, the first 2 minutes is only fixation. The staining is the next 7 minutes. Okay. And how do you know that your staining will be good? You get to see a golden scum on top. You'll be able to see a metallic sheen on top, which is basically nothing but eosin thiosinate. It's just a compound which will help you understand whether your staining, your mixing is good or not. Okay. Now remember, this golden scum is actually a thick stain particles. So you should never allow the golden scum to touch your smear, because if it touches your smear, then it will cause stain precipitate. Okay. So when you are, you should not, that means you should not allow it to dry. Okay. And after 7 minutes, when you're going to wash it off, don't invert the slide. You're supposed to flush the slide, not invert it. Because if you invert it, the scum will touch the slide. The scum touches, and if it dries also, the scum will touch the slide. If the scum touches the slide, there will be stain precipitate. Okay. So if stain precipitate is everywhere, you won't be able to see this smear properly. Then always remember to wipe the under surface. Okay. And dry it in a tilted position. So ideally, the smear should be pink in color, where the RBCs are red and WBC nucleus as well blue. Staining problems, you can have overstaining, understaining, or strain deposits. So this is ideally what it should look like. Nice pink color, and when you look under the microscope, you'll be able to see RBCs are nice and red. What cell do you think this is?
eosinophil.
Very good. Eosinophil. Okay, so this is the head where everything is very dense. This is the tail where again where density is very less. So ideally, we should see the junction of the body and the head where you'll be able to see the morphology properly. And nowadays, all the slides that we get have a frosted area, so it's very easy to label here. Okay? So you don't. Otherwise, if you get a plain slide, remember to always leave a 1 centimeter gap so that you can label. When does a stain get overstained? And when does a smear get overstained? If it is a very thick smear and you keep it for staining and you forget about it, that is prolonged staining time. You don't wash it enough, okay, or you would let it dry so the scum touches it, okay, then increase alkalinity. Understaining also, it's pretty logical answers. Insufficient timing, or the stain is bad, or you have washed it too much, or increased acidity. Stain deposits, if your slide is not good, or if it got dried, or if it got tilted and your stain fell off, if you didn't wash properly, or you didn't filter your stain particles properly, so the deposits are formed. Correction, if it is overstained, what you have to do is just pour your stain. That is, your Leishman stain is basically 0.15 gram Leishman powder in acetone-free methyl alcohol. So you just pour your stain over it, let it stay for 15-20 seconds, and then wash it off. So that acetone-free methanol itself will dissolve the stain particles which are stain, the excess stain that is there, and it will wash off. Okay. So remember this. How will you correct it? It's okay to make a mistake, but you have to know how to correct it. You overstain it, you have to pour your acetone-free more stain and heat for 15 to 20 seconds. The fixative in the stain will wash off the excess stain. If you have understained, then it's very simple. You have to stain it for some more time. Okay. So staining, remember, staining starts only when you pour the stain plus the distilled water. So you have to put the stain and twice the amount of distilled water, and then stain for some more time, and then wash it off. Okay, the first 2 steps, first 2 minutes is only for fixation. Don't forget that. Now this is just an idea of understained. You can see something is there, but you're not really sure. This is ideal, and this is overstained. Everything is so dark that you're not able to understand much. So this is ideal. So one more time, if it is overstained, what will you do? Hello? If it's overstained, how will you correct overstaining? Over, class is almost over. You can just tell this answer and then I'll finish fast and go.
We will add methanol.
Not only methanol, you can't answer incomplete. Incomplete.
Acetone-free methanol, 15 to 20%.
Okay.
Sorry,
15 to 20 seconds and then wash.
Seconds.
Okay. This is just an example of stain deposit. You can see all these are stain deposits. So you'll get confused with what? Stain deposit causes problem with what? You'll get confused. Where is a platelet? Where is the stain deposit? Understood? So it causes a lot of problem with platelet counting especially. That. Okay, done. Have a good day. Thank you.